Terry and Fiona. So moving on, I've got another piece of paper here. Now, in this next half an hour, from 7:30 to 8 o'clock, we're going to be talking about population studies and what they tell us and how evaluating services is raising standards. Hello to Fiona Matthews, who is a professor of epidemiology at Newcastle University. Hello, Professor Matthews.
Hello, Adam.
And also Dr. Terry Quinn, who is a senior lecturer and consultant. So this medical consultant.
Yeah.
Neurologist, psychiatrist.
I'm a geriatrician.
Geriatrician
For older people. So
consultant for older people as well at the University of Glasgow, and I'm guessing in the NHS as well.
Yeah, I'm in my NHS office at the moment. Just finished the weekend on call.
And you, of course, also work with Cochrane.
Yeah.
Which we're going to talk about as well. Oh, and in fact, I have a separate piece of paper for you. You sent me an email. I didn't get a chance to copy out the notes before. Thank you very much for both joining us. So we're going to chat now over the next 25 minutes. Fiona, could I perhaps come to you first to ask you to initially introduce yourself?
Yeah, so I've worked over for a rather long time, a lot longer than some of these early career researchers who've been chatting in the last half an hour. Fantastic. In terms of population studies, so that's trying to go to large numbers of older people, not just those with dementia, though we do some studies just on people with dementia and their caregivers. But actually, we, across the spectrum of older people, and look to find dementia not necessarily with people who will have a clinical diagnosis of dementia. So trying to really understand the disease and where it fits on what is a continuum of normal life from a complete older population perspective. And so we tend to do the complete opposite of your last two speakers. We do studies with very large numbers of people. The larger, the better, to get a better population representation. And so we sort of knit at the other end of the spectrum, and then look into those people's lives, and then think about how is that going to impact on the health of the public health. Moving forward and project forward and think about the numbers of people with dementia that are going to come into the clinics, into the health system, into the care system over the next 20, 30 years. So that's what we do in the population health sphere.
I mean, and that's important itself, isn't it? Because I mean, helping to, sorry, I'm wheeling over a piece of paper. To help shape those services so that they're not suddenly surprised when the number of people start to double coming into memory services, for example.
I mean, it's really important. I mean, things that we know, obviously, you know how many roughly 65-year-olds, 75-year-olds, 85-year-olds there are going to be over the next 10, 20, 30 years. And actually, so we can sort of start to plan the numbers of people who we'd expect to get dementia based on what we know now. But what we equally know is that each generation's risk of getting dementia and these risk factors and lifestyle factors that I know guests have talked about and things like that are different for each generation. And so the next generation might not have the same numbers. And so you have to understand that each time so that we can plan over a longer term, a short term and a longer term, so that we can really think about what services do we need, where do we need them, when do we need them, and for who do we need them. And that's the crucial part. And it's exciting to think about potential. Then we also think about, well, what is the potential of a treatment effect might have on that, or what is changing, say, the number of people who get strokes, how will that then impact on what happens with services, what happens with people with care. What's the obesity epidemic that we're seeing in midlife now going to do in 30 or 40 years to the people with dementia in the future? And so that's what we do as epidemiologists, and try and understand those trends and think about what they might mean to what the population is going to do.
And is that something that is that something that somebody, I mean, I guess, I asked this same question of Martin Knapp earlier, is this something that somebody would commission and come and ask you to do as well? I mean, do you do this service for the is this something you have to seek funding for and then you publish and share, or do people ask you to do it? Is this a commissioning thing?
A bit of a combination. So we have so setting up the studies in the first place is usually we want to do the population-based study, so we set up the base and go and get all that. Interviewing people in their own homes, trying to find people with dementia, people with cognitive impairment, people with of the whole spectrum, because what you need to do is you need to follow people from as they age. So we need to do this as longitudinal studies. So we go back to the same people over after a couple of years or a year maybe, and then we see them again, and we will see, then we can track what normal aging behavior is. And this is one of the frustrations of an epidemiologist, is people age quite slowly, and I age at the same time. So if I'm setting up a study now, it's sort of in 20 or 30 years time, I wouldn't be seeing the results of it, but that doesn't mean that it shouldn't be set up and it shouldn't. So this is what we did. But then sometimes things like we have worked for Public Health England, which has been in the news recently. It does chronic diseases as well. We've worked for Public Health England to help them with understand what the dementia rates are in the population and how that is being diagnosed at the moment.
But is that where you can, would you be one of those people that's kind of using new technology to cheat and skip ahead? This whole idea of artificial intelligence and machine learning allows you to not have to wait and see what happens or if check you're right, because I've seen it on movies, you can just press a button and it'll show you a map and it'll just exponentially grow, and you can tweak a little factor and it'll model it. Is that,
yes,
is that sci-fi?
Yeah, so we model it, but we don't know in my lifetime if I'm right or not. But yeah, I mean, you have to model the scenarios and you have to model how things might work within some areas of confidence. So we can't say in 50 years' time there'll be an exact number of people with dementia. There will be a range of values, and it's up to the services to then be able to say, well, that might be 960,000 people in 2 years' time. It might be 960,000 or 1 million people in 5 years' time. So you have to sort of think about exactly what range you're going to be able to cope with, and it's then explaining that sort of error, or as it were, that uncertainty, as we in statistical terms, to clinicians, because we can't tell you exactly what's going to happen, and never can, but you need to understand that for understanding the different services and things. So it is about prediction. Yeah, we predict as machine learners also predict. I'm a statistician actually by training, but it's a similar thing. We predict how many we think there are, and confidence around that.
And I love I mean, I don't know how much of this you managed to do, but going from that kind of general down to the specific, because one of the things that I've always been excited by, so I've worked with memory clinics and things like this over the last few years in trying to encourage them to support more research, and right down to GP surgeries. And when you start to unpick things down to the individual numbers that kind of I really like, when you start to say to somebody, well, you need to start talking to patients, and you bring this down and say, well, you're saying this is too much work, but it's you see 6 people, you don't see 600, it's 6 people a month. And I find, I don't know how down to local communities and specific your modeling can go.
Well, we sample the population. We've always sampled the population from GP surgeries, and I've always been thankful for the GP surgeries that are happy for us to go to their patients, because they're not ill. A lot of them, they're not people with dementia. They're not people necessarily with the dementia diagnosis, but you can plan down to the level of a surgery in terms of, the age and the demographic and the sex breakdown of that surgery. So you could say to them, we would expect you to find X number of people within this, but actually, it could be 3, it could be 6, it could be 2, it could be 8. And GPs, that's not really, it's not a target. We're not saying to people and saying to GPs, we think you've got 5 people with dementia in your surgery, go and find them. That's not what this is about. This is about, finding the whole population and working out where are the changes, where have we seen changes, and then looking at what people have, their lifestyles, their lives, and and thinking about what might have contributed to that risk of getting a dementia, which is, as we know, is multifaceted, and there's it's not one thing that's going to have meant, okay, right, tomorrow because you've done that today, tomorrow or in 50 years time you're going to get dementia. It's not like that. It's a multifaceted disease,
and having the numbers is important. I mean, I know that that's been used recently by the NHS, for example, to try and understand, to get its benchmark on how many people are diagnosed and how many is going to be improved. And I'm guessing numbers are important to raising standards as well, Terry, because I'm going to ask you now because I know you're involved in the Cochrane work on dementia, and I'm guessing having underlying good, reliable statistics and modelling numbers has to be one of the things that underpins raising standards as well. Tell us about, can you tell us a bit about Cochrane and the reviews and what they do?
So I guess like Fiona, what you're going to hear from me is very different from nanoparticles and some of the other things that other speakers have been talking about. So
I'm sure you're all equally as likely to get your Nobel Prize.
I've not heard from the Nobel Committee yet, but so in Cochrane, what we do, I would call meta research. So it's research that's using research as the building blocks. And what we are particularly interested in is pulling together and collating the research that's out there and trying to synthesize that and to make sense of it, and make sense of it in a way that can be helpful to clinicians, to researchers, to people that write guidelines. Because we always say, and people today have been saying to you, that there's not enough dementia research, and I would absolutely agree with that, but it wouldn't be true to say that there's no dementia research. There's actually lots of research out there. There's an exponential increase in the amount of research. Every few seconds a new research paper is published. So what we try and do in Cochrane is pull that together for people. Pull together research on a particular theme or on a particular question and make a sense of that. Appraise the studies, separate the good studies from the bad studies, and bring it all together to give a message or a recommendation. And so you mentioned numbers. One of the reasons why Cochrane is important is traditionally in dementia research, and I'm not talking about Fiona's work here, but in other studies, numbers can be quite small. Trials of treatments in dementia sometimes only have small numbers of people living with dementia included. So in Cochrane, what we're able to do is take 4, 5, 6, 7 different papers, different studies that have looked at an intervention and pull them together. And by pulling them all together, you start to increase your numbers. And then you start to increase the power that you have to maybe see if there's a treatment effect there. Something that might have been lost in each individual paper can be found by bringing them all together.
That sounds like hard work. I mean, one of the things that's come up, one of the things I've tried to pin people down a little bit about today, because if I was watching this chatbot today as a member, I'm a bit of a research insider, because obviously we do research as well. I do research where I work at UCL. As much as I'm doing this on my own time, if I was a member of the public, one of the things I'd be trying to pin us down to is what's the point? What if you finished your PhD? How is what you learn over that 3 years, and that we've been telling everybody it costs £30,000 a year or £15,000 a year to fund a PhD student. So over that £45,000 that costs to put somebody through a PhD, how is that being used? And it's been quite hard sometimes, and that's not because the researchers as individuals, but their job came with so much funding to find out what they needed to find, and then putting that to use is tricky, and getting organizations to do that. Is that one of the things that Cochrane can do, is to pick out those bits and say, look, this finding is important, this is what is that something they do?
Yeah, I mean, it's one of the things we do. It's not the only thing we do, but it's certainly one of the things we do. So in that huge tsunami of research that's being published all the time, we will prioritize certain questions that we think are important to clinicians for guidelines, and we will take out all the papers that are relevant to that particular question and try and pull them together. So we know that within your example of a PhD, we know that within a PhD, you're unlikely to have a finding that's going to completely change practice, but it's a building block and we take those building blocks together to try and make something that's bigger than the sum of the parts.
Yeah,
It's
I guess
not-
when you're getting an overwhelming number of results that come back and saying the same thing, it's by putting them all together that's going to. And so how do they go about prioritizing?
Yeah, so we get priorities from various places. We work with guidelines and commissioners. So bodies like NICE and SIGN will sometimes say an area that they are interested in. But increasingly, one of the things we're doing, and this is something you'll be interested in, Adam, is we're working with people that are living with dementia. And we're asking them, look, what's important to you? Because I think we've maybe missed a trick in the past by being guided by the researcher's agenda. And even within Cochrane, I think we've maybe been guilty of that in the past. But actually, if you ask the people who are living with dementia at the moment what's important to them, you can use that to choose the questions that you want to try and build evidence on. And if we go to the evidence and we find that there's nothing there, that's still an important finding, because we can then say to funders, look, this is important. We've searched the literature. There's nothing there at the moment. This is where you need to be putting your money.
And I think that's a tricky one then, though, isn't it? Because it depends, depending on who you ask will influence the results you get. I mean, I remember, it's quite a long time ago now, but Alzheimer's Society asked, working with the James Lind Alliance to do the research priority setting partnership for dementia, and they also did one a little while later for Parkinson's disease. And you couldn't help but notice that when they did this for dementia, a lot of people were asking for care to be receive the priority. Yeah. And that's because I guess a lot of the people that filled this in were family carers, and they were, struggling to deliver good care or know what was best to do, and that's what they went with. When you looked at Parkinson's, where many of the people who feel this were people who are living with Parkinson's themselves, treatment was one. And do you find different populations will influence then what they want researched? Family members and people who are at risk are more likely to say, tell me how to prevent ever getting Alzheimer's, whereas if you go and survey or ask a bunch of people over 75 willingly, they're going to talk about care rather than treatment.
But people always will, won't they? And that they want to know the answer to the most important thing to them. And it's up to us as researchers to listen to what is the most important thing to them, and then put that. If you ask enough people, you'll get a real range of views. And that's the thing, is that, if you're going to involve the members of the public in your research, as I think you should do, that actually you can't just ask one person, because you'll only get one answer, and it's such a complex issue that different things will be of interest. And what's great about the Cochrane, as Terry said, was that actually it doesn't matter whether the answer comes back saying yes, we know the answer, or the answer's complicated. It's the mixed results. There's no answer there to be had. That's all of it is useful for the next generation of researchers, because we either move straight into the clinical guidelines, or you've got, well, this is an interesting question that needs answering that nobody's looked at yet. And that moves us on to the next thing. And I think that's why, we've been doing a study down in Exeter with, I think you might have had Catherine Quinn on from also involved in the IDEAL study, where actually we've got a cohort of people with dementia and their carers, and we're actually following them as dyads, so that actually that relationship between the carer's needs and the person with dementia and how to live well with dementia is being looked at by both viewpoints. And actually we don't always involve both viewpoints within the research on dementia, and that's also really important, that the carers get their side of the story across as much as the person with dementia. And I think that they will also have some interesting questions that they want answered, and we need to involve all of them, really.
Yeah, I don't think there's a competition between research looking at care, research looking at cure. There's room in the dementia research world for all of those things. So we have streams in Cochrane that look at diagnosis, we look at prognosis, we look at prevention, we look at treatments, and we look at living well with dementia, and we look at care and care-related issues.
And I think and that continues to add to the great thing about the mix of funders we have, that the funders are all funding different things, which means that all of this can continue to happen That's why I've been lucky enough to have so many people representing different fields of research to join today. A lot of the people that have talked to us today are early career researchers. In fact, the majority of them, I'd say, are early career researchers, which I think is fantastic. Anybody who's been to a dementia conference in the last few years can't help but notice that the number of young people or people under the age of, I'm going to pick anybody under the age of 35, under the age of 30, the number of people falling into that group, there are more people, I'd say, under the age of 35 now at the conferences than there are, you know, older people over that age. How does Cochrane work with early career researchers?
Yeah, so unfortunately, I'm not within your definition of an early career researcher anymore.
No, but you look under 35.
I still remember those days. So, I mean, supporting early career researchers is something that I feel very passionate about, and it's something that we've been doing a lot of in Cochrane Dementia. We have fellowships that allow people to come and work with us. We have people come and work in our main offices in Oxford. That's something that I did a long time ago, and that's how I got involved in Cochrane. And then, you know, I became more involved over time. We also have, the beauty of Cochrane is you can work on systematic reviews from anywhere that you have access to a computer. So we try and have researchers from across the world working with us. And although I'm obviously biased because I'm such a Cochraneite, I think anyone getting involved in research, it would do them no harm to work on a systematic review. And if they want to work with us, that would be great, because through working on the review, you learn about dementia, you learn about your topic, but you also learn things like how to read a paper properly and how to really critically analyze that paper and see which aspects of the methodology are good, which aren't so good, and how to put that in the context of everything else that's happening in a particular research space.
Well, and they're essential, you know, those are lifelong skills for an academic. So is coming to work for Cochrane something you can do on a short-term basis, or is this something you have to apply to do and do for a, you know?
It's not a life sentence. So you can get involved as much or as little as you want. So at one end of the spectrum, one of the information scientists that works with us, Anna Noel-Starr, has set up a platform called Cochrane Crowd, and you get some online training, and then you're part of a crowd of thousands of people that help us to pick out dementia-specific titles. And if you want to get involved in Cochrane Crowd, you can just Google Cochrane Crowd and get enrolled there. And then if you're really interested, and if you get the bug, you can lead your own review, and we're always looking for new author teams to work with us.
So that sounds, and I guess information on how to get this is Cochrane's got a website. You've been, I mean, also a social media presence. You've been so incredibly supportive of the event over the last week or two in sharing on social media. I swear so many people have joined today just thanks to your own promotion and your own very generous donation as well, Terry. So thank you ever so much for getting colleagues to there to promote this. If anybody has any questions for Terry and Fiona, please do post them now in the YouTube comments box or in the Q&A box. We do have a question already. It came in, and this is a familiar name to me. This is somebody I worked with a few years ago, I think, but Dominic McGrath, also known as Terry McGrath, who used to do the patient and public involvement work for Dendron back when the Dementia and Research Generation Network was a thing a while ago, asks, do you have a, he's a famous, he just points to remind me he's a famous actor now. He left and worked to retire and to take up acting. So tell us, do you get a sense of whether dementia service standards are worsening or improving? Now, remember, this is independent. You can say what you really think. Are they getting better or getting worse? Go on, Terry, you take that one first.
Okay. So a disclaimer, I wouldn't say that assessment of dementia services is a thing that I do a lot of. I mean, thinking about when I first got interested in dementia clinically, I've seen big changes, and I've seen big positive changes. I guess I'm worried about the effect of COVID, as is everyone, but I'm worried about the fact that it's now difficult for me to see patients in person. I'm having to do assessments over a video call like this or over the phone. And I fear that we're missing something through that. And also a lot of the support that's there in the community for people living with dementia also is on hold at the moment because of social distancing. And I really am worried about the isolation that's causing, the effect that might have on dementia. So I guess up until the beginning of 2020, I was very happy with how services were progressing. I'm worried now.
Yeah, I agree. I think that's very insightful and a very honest answer as well. I think memory services, provision, waiting times, diagnosis has definitely improved. There's no getting away from that. But the long-term effects, and depending on how long this pandemic, the restrictions on population because of the pandemic continue, will remain to be seen. There was a question now from Chris as well, who says, does Cochrane do reproducibility research in dementia, i.e. checking the reproducibility of trials and analysis, and is this active in open science culture? I'm going to say no. I'm wrong.
I would like to think it's getting better as well, but there's still, there's work to be done. I guess what we do in Cochrane is we pull together lots of studies on the same theme, and we'll look to see if there are differences between those studies. What you often find is that the study that makes the headlines that everyone knows about, the one that had the big effect, is just one of many studies on a particular topic. And when you look at those other ones, they maybe didn't have such a big effect. And by pulling them together, you get closer to what the real value is, to what the truth is. So I guess in that way, we're sort of doing reproducibility research.
But yeah, through the comparison, even if you're not trying to replicate the trials, that makes absolute sense. We're out of time. Thank you very much, Dr. Terry Quinn, Professor Fiona Matthews as well, for taking your time to join me this evening, particularly at the end of, clearly you haven't even gone home yet, Terry. Are you on a night shift or are you heading home now?
It's home time now.
Go home and get some dinner. Thank you very much for finding time to join me both. And if anybody's got any further questions or follow up, all the information on Cochrane is available on our website. We've also been retweeting them as well. And you can find profiles and their Twitter names on our researchers page on the website. So please do get in touch. Thank you very much, both of you.
I'll just get a quick plug. Anyone that's interested can also email me directly if they want to get involved.
Oh, go on. Yeah, go on. Share if you want.
Okay. Bye now.
Thanks very much, Terry.